risk of causing problems. So you've got to, sort of that, always that balance of getting it right, you know, not overdoing it. You know, perfection is the enemy of good. I'll move on. How am I going for time, all right? These cases are quicker. This is a 39-year-old Indigenous guy. He comes into ED, he's heavily intoxicated on meth. He's complaining of shoulder pain, he's agitated, he's sweaty, and the ED staff said he wasn't safe to examine. So they actually sedated this guy. He was given sedation at 4:30. That is his ECG at 4:20, and doesn't look too bad. Maybe there's some ST depression, but it is after an ectopic. The thing with this guy, he's actually had bypass surgery 2 years ago, so when he was 37. 2025, this is 22, so 4 years ago, when he was 35, so pretty young. At 7:30 in the morning, and I've just got home from the next case I'm about to show you, I get a call. I've been in bed for about, an hour, saying, oh, this guy's got ST elevation on his ECG. So he's pain-free, he's still asleep. So, see here is these three. He's got stonking ST elevation. He's still asleep. He has been sedated. So I'm like, you know, what's happened? So he's had meth, maybe he's got meth vasospasm. Give him a spray of GTN, see if it goes away. Call me back in 5 minutes. They call me back in 1 minute and say, it's all gone away. I said, did you give the GTN? Oh, we didn't have to, it all went away. You know, I said, put a GTN patch on, maybe he's got spasm from the meth, you know, causing the coronary to shut down. Give him dual antiplatelets, and we'll just see what, you know, it's a Sunday morning, we'll see whether we can, you know, let him wait till Monday. So you then, his ECG gets better. That's his ECG when he's better. And so at 8:01 I think it is? 8:01, they're handing over, the day reg is taking over from the night reg, and they ring me up and say he's woken up with a bang, he's agitated, he's got chest pain, they resedate him, he has a veer for rest, they shock him back to normal rhythm, he arrests again, they do CPR for about 6 or 8 minutes, cardiovert him, get him back, and we take him to the Cathlab. So he gets intubated because he's so agitated, and this is his ECG from 2022, so 4 years ago. So his right coronary artery on the right-hand side's got some disease. It's not really a big vessel. And his left main, don't know if you saw it, but he had sort of severe distal left main disease. So they've sent him off for bypass surgery and grafted his left anterior ascending, his intermediate artery and his circumflex. So I just thought I'd sort of talk about bypass grafting a little bit. So, usually we have this internal mammary artery. We usually use the left internal mammary artery. I don't do it because I'm not a cardiothoracic surgeon. Surgeons do it. It has all these branches that come off it, so I've got to tie these off. They dissect it off your rib cage anteriorly, and then they swing that down to the heart and sew it onto the LAD after the stenosis. So, cardiothoracic surgeon, it's like orthopaedic surgery, then a bit of microsurgery, and then back to orthopaedic surgery to close it all up in the end, right? They're pretty good surgeons. So the other options are you put a vein graft on, you may punch a little hole in the aorta, sew that onto a branch. You can use a right internal mammary artery, so you do the same as you do for the left. Technically challenging, you've got to get to both sides of the body. You can swing that on. But the arterial grafts, if you do them right, they last for longer. As vein grafts, they're made to have a pressure of like 5 to 10 millimetres of mercury, not 150. And then you can have a radial artery graft, which is how I do most of my angiograms, which you can also use as a conduit. So this is not this guy, this is one of my colleagues' dads, who's a patient of mine. And so he's got, this is just a CT scan just to show you, you can see it coming off the subclavian artery, and then what they've done is actually they've sewn a radial artery graft onto the lemur, so that supplies the circ, and the lemur, the left internal mammary, comes down to the LAD. So he's had full arterial revascularisation, so that you don't 10 years down the track get blockages in your vein grafts. So this is this guy, back to this guy. So that's his left main. It's got a bit worse. It's like critically narrowed, and there's a circumflex artery still supplied. It comes off that. But the LAD and the intermediate artery, which came off there before, are no longer there, but they've been grafted. So that's what it was before compared to now. So you can see there are lots more branches coming off it than there are now. This is his right coronary artery now, so it hasn't really changed. This is his right internal mammary artery. So we go up from the leg. We go from the leg usually if they had bypass grafting, otherwise you have to go through both wrists. So that looks okay. There's some disease down in the intermediate, and there's a bit of a narrowing there, but it's not causing his ST elevation. And this is his internal mammary. Beautiful graft, but you can see just after it's tied onto the LAD, there's a critical narrowing in the LAD. So we pass a wire down, so use like a Seldinger technique. You put a wire down, then you put the balloons, they've got a little hole in the balloon for the tip of it, and that slides over the wire. And the stents are just crimped onto the balloons that we use for balloon angioplasty. So we put a wire down his LAD, then we balloon it, put a stent in, try to not stent from the internal mammary artery if we can avoid it, but sometimes you have to, because sometimes that will block off the blood supply going back up the LAD. Looks pretty good. I did that intravascular imaging just because it's really critically important. I know that this guy, he's into meth, he's living on the streets, got no fixed address, he's probably highly unlikely to take his tablets, so you want to make sure the stent is like perfect so that if he stops taking his antiplatelets, the stent won't block off. And looks pretty good. Actually, it's a huge LAD, it's a wraparound LAD, wraps right around to do, saying how his right coronary wasn't very big, that's because his LAD goes halfway up the inferior wall of the heart. And then we do the same thing, stent in there. You can see there's a weight there, so we have to come back and balloon that at very high pressure. He did have a little dissection. That's a dissection caused by me this time. So we just put another stent in there. Just, because you're ending in plaque and ballooning it open, if there's disease there, it can split. So you always try and go to from normal vessel to normal vessel. And get a pretty good result from that. So now he's fully revascularised. Actually took him about 7 days to get him out of ICU, because every time they woke him up, he'd sort of freak out. He stepped down to CCU. He actually had a myopathy from being in ICU on a ventilator. So I rang the registrar, because I actually went on leave after this weekend for Christmas, and I was looking him up before I came to do, getting this talk ready, and he had to sort of hobble out of CCU because his myopathy, he couldn't actually walk. But they got it seen by the ALOs, he got seen by the psychs, he was able to make a decision, and he discharged himself. So I'll just show one case quickly, just because it's a sort of a new technology. 61-year offshore mechanic, transferred by you guys, by the AMBOs. He's had 6 hours of someone sitting on his chest. His GCS when he came in was 15. He's got a history of hypertension, but his wife said that 3 times while he's had the chest pain, he's just like passed out, hit the floor, and then woken up again. So he's got a lac on his face. So he's probably had some short runs of VT or VF. He's in shock, hypotensive, pH 7.1. Really wanted to take him to let's do a CT head. I said, let's just get him up to the Cathlab. We've got to open up his artery before he arrests again. So this is his ECG. Ugly right bundle branch block, ST elevation through all of his anterior leads, and ST depression in his inferior leads. So here's his angiogram. His right's blocked. But you can see there's these sort of branches that kind of go quite a long way, and there's a bit of filling there, so you think, well, maybe actually this is chronic, maybe this isn't something we have to do. And this is his left, so he's got a circumflex, but his LAD is totally missing, so he's got a proximal occlusion of his LAD. So we fix it. Balloon it. Get a reasonable result. You know, there's not great flow down there, and that's one of our limitations. You know, if you get this no reflow, if the artery's been blocked for a long time, you know, when you balloon out all this clot, some of it goes distally and sort of clots up the small blood vessels. Anyway, this guy, again, I go on leave for a week. That's right. I'm not on for coronary care, I'm just on for the angioplasty. So this is the case before the last one I presented, the same night. But he's ongoing inotropes because he's hypotensive. His troponin goes to 400,000. He's not perfusing his kidneys. He's on dialysis. He's got severe LV dysfunction, and he's got severe or torrential mitral regurgitation. So you can see in his echo, he's got this, every time the heart beats, he's got this huge jet of regurgitation going back into his left atrium. So they do a angiogram, and you know the stent looks good, so it looks better. So there's often vasospasms. So you, again, like I was saying, you know, perfection is the enemy of good. But it looked good, wasn't due to that. And the right coronary, was also filling from the LAD. But this is his mitral valve and a transesophageal echo. So we put the probe down the esophagus, we get really good pictures. And you can see he's got this huge regurgitant jet from the left ventricle back into the left atrium every time the heart beats. So, you know, most of the blood's going back, not forward. So he's had bypass surgery. I mean, he's had revascularized his stents, he's on dual antiplatelets. You know, sending a guy like this to surgery, the likelihood of survival is very poor. So now we sort of have some options, okay? So this is a 3D reconstruction of his mitral valve. So you can see there's this huge hole. When the leaflets are supposed to come together, there's just this great big gap where it doesn't, you know, that's part of the remodelling of the ventricle. You know, the papillary muscles that go to the leaflets, that's all involved. So when you get ischemia, it can really stuff you up. Huge amount of regurgitation. So this is MitraClip delivery system. So you have this little clip device that you're trying to catch the mitral valve and pull it together. So you see up here on the top, there's the device when it's open, and there's two little skinny bits called grippers, and you want them to come down and capture the leaflets while the heart's beating, and then you sort of pull it all together and hopefully pull the mitral valve together and cinch it together. This is all in fast forward. It's me scrolling and recording on my phone. So you've got to put these great big tubes in the heart. You've got to puncture you've got to go in the right, you've got to go in your femoral vein up to the heart, puncture through the septum between the left atrium and the right atrium, put a very big tube in across that, so you're sort of creating a little ASD, which mostly heal up. And then you get this device, and you can steer it, and then you push it down, and the toe, that's the toe probe, the big black thing at the top. The echocardiologist pretty much tells the interventional cardiologist what to do. So you put it across that hole or that leak, try and line it all up, and you might see, it's not going to play that well, but put it in all the right spot, and you can't really see the grippers going down, but you could if it was playing better. But you make that mitral regurgitation much better. So this guy that's been in the ICU intubated for 8 days is extubated the next day. And you can see this is the device here. It's actually created a bridge and just pulled the mitral valve. So you've got a 2-lumen mitral valve rather than one. There was a cardiothoracic surgeon called Alfieri, this Italian guy, who used to do this operation where he just sewed the anterior and the posterior mitral valve leaflets together for mitral regurgitation. That seemed to work a bit. Not as good as a repair, so it's sort of based on that. So, you've got to look after yourself. Don't take meth, don't smoke. Check your cholesterol, check your lipoprotein A, check your blood pressure. These are all modifiable risk factors. Check your blood sugar because you can do something about it. This is us guys when we were young. Chongi, Gordon, me, another friend of ours, Roger, who's not actually with us anymore, unfortunately. You have to watch out for trees because they're non-modifiable risk factors. Sometimes along the way you have to have a few little repairs. This is after Gordon let his surfboard go while we're surfing and hit me in the head and split my head open and Chongi sewed me up. And then hopefully you'll get old and even Gordon, you know, back then it's looking pretty good. But you know, we're all getting old. We can't do anything about that. That's not a modifiable risk factor. Thanks.
Thank you very much, Matthew. Any questions for Matthew? Yes, down the front here.
You said that those ASDs mostly heal up. Like, how often are they persistent, and do you see increased strokes in those patients?
No, well, you don't actually see strokes very often with ASDs. You see them with PFOs, and part of that's the whole process of how it's sort of, how your septum works. Because when you're in utero, you've got it's a flat valve, your PFO, to let blood. You want blood to go from your right atrium to your left atrium. So when it's just an ASD, you don't sort of seem to get as strokes like you do with PFOs. So you can tolerate a small one. Sometimes, if there's a shunt and you think it's hemodynamic significant, you can close it with a percutaneous device. But usually they just shrink. They often are sort of almost gone the next day, and then they sort of shrink down and then close up. Yeah.
All right, let's hear it one more time for Matthew and our wife, who's actually this afternoon.